All right, let's jump right into a case that, well, on the surface, it seems pretty straightforward. But as you'll see, there's a really critical twist. This is a story all about swelling, sure, but it's really about spotting those subtle clues that point you towards the right and sometimes life-saving treatment. So here's the scene. We've got a 59-year-old man. He goes to bed feeling totally fine, but then he wakes up to something pretty terrifying. One side of his tongue and his lower lip are seriously swollen. You can imagine the panic. His wife immediately calls for an ambulance, thinking this has to be a severe allergic reaction. The paramedics, totally reasonably, treat it like the worst case scenario, which is anaphylaxis. But then he gets to the emergency department and the picture just doesn't quite fit. You know, all those classic signs you'd expect to see with a major allergic reaction, they just weren't there. Okay, so the first responders absolutely did the right thing, but the puzzle pieces just weren't lining up. So let's take a look at the clues the emergency team started putting together, clues that began to point them down a very different path. They gave him the whole shebang for anaphylaxis. We're talking adrenaline, antihistamines, and steroids. The standard playbook. And here's the absolute kicker, the most important clue of all. It did nothing. Zero change. His swelling didn't budge.
And this is where things get really interesting. I mean, look at this guy. He's got this dramatic swelling, but he's talking completely normally. His breathing is totally fine. All his vital signs are stable. There's no rash, no hives, nothing. He's surprisingly okay. And that just doesn't scream anaphylaxis, does it?
So, all these observations start to steer us away from anaphylaxis and toward the real diagnosis here, which is something called angioedema. But here's the thing. Getting that diagnosis is just the first step. It immediately brings up the one critical question we have to answer if we're going to treat him properly.
So what is angioedema exactly? Well, it's this deep swelling under the skin, and it's what we call non-pitting, which is just a fancy way of saying if you press on it, it doesn't leave a little dent like some other kinds of swelling. It loves to show up in places like the lips, tongue, and around the eyes, basically anywhere the tissue is a bit looser and there's more room for fluid to build up.
And this gets us to the absolute core idea of this whole thing. See, angioedema isn't just one thing. It has two totally different causes, two different pathways. One is the one we all know. It's driven by histamine, the main culprit in most allergic reactions. But the other is driven by a completely different chemical called bradykinin. And figuring out which of these two paths you're on, it's everything. It's absolutely crucial.
So how do you tell them apart? How can we figure out if we're dealing with histamine or bradykinin just by looking at the patient? Let's dig into that, because if you get this wrong, your treatment is going to be completely useless.
Okay, this table really breaks it all down. Think of it this way. Histamine is fast and furious. It comes on quick, usually within an hour. It's almost always itchy and comes with a rash or hives. And then it's gone pretty quickly. Bradykinin, though, it's the slow burn. It can take 12 hours just to reach its peak. It's almost never itchy, and it can stick around for days. Now think back to our patient. His story fits that bradykinin picture to a T. All right, so if we're thinking bradykinin, the very next question is why? What's triggering it? And the first place you should always look is the patient's medication list. The number one culprit, by far, are drugs called ACE inhibitors, super common blood pressure meds. And what do you know? Our patient was taking one called ramipril and had been for years.
The way this works is actually pretty simple. Your body makes bradykinin all the time. Normally, an enzyme, the ACE in ACE inhibitor, comes along and cleans it up, breaks it down. But if you're taking an ACE inhibitor, that drug blocks the enzyme from doing its job. So the bradykinin just starts to build up and up and up until you get this crazy swelling.
So why are we making such a big deal about this difference? Histamine, bradykinin, who cares? Well, you have to care because it leads you to a massive fork in the road when it comes to treatment. It's like this. If you're on the histamine path, all the usual anaphylaxis stuff, adrenaline, antihistamines, it works. But if you're on the bradykinin path, those drugs do absolutely nothing. They are completely ineffective. And that explains exactly why the paramedics' treatment didn't touch our patient's swelling. Now, I have to say this, and it's super important. Safety always, always comes first. If you are in any doubt, even a little bit, you treat for anaphylaxis, period. You cannot afford to miss that diagnosis. But once you've ruled it out, once you're confident that's not what's happening, you've got to switch gears and come up with a totally new game plan. Okay, so we're pretty sure it's bradykinin. What now? What's in our toolbox? To be honest, the evidence for some of these treatments isn't as solid as we'd like, but there is a playbook we can follow. A lot of the time, especially if the patient is stable, the best thing to do is just watchful waiting. Just keep a close eye on them. But there are other options that go right after the bradykinin itself. One is giving fresh frozen plasma, or FFP. It basically contains the very enzyme that the ACE inhibitor is blocking, so it can help break down all that excess bradykinin. Then there's the specialized drug called icatibant. It works by blocking the receptors that bradykinin attaches to. Sounds great, right? Well, here's the catch. A single shot costs something like £1,500. And what's worse, the best study we have on it was pretty small and found it didn't really work any better than a placebo. Ouch. Now compare that to good old fresh frozen plasma. It's cheap, it's sitting in the blood bank of pretty much every hospital, and even though we don't have huge studies on it, there are a ton of case reports showing that just 2 to 4 units can make a huge difference, and fast. So what about our guy? Well, thankfully, his swelling wasn't getting any worse by the time he got to the ER. So they watched him carefully, and this is the most important part. They stopped his ACE inhibitor. And that was it. He was stable enough to go home later that very same day. So let's wrap this up. The biggest takeaway here is this. When you see angioedema, you have to immediately think about those two pathways. Is it histamine or bradykinin? The timing, the fact that there's no itch or rash, and that the standard allergy treatments don't work, those are your giant red flags. And please, always, always look at their list of medications. So I'll leave you with this question to think about. The next time you see a patient with this kind of swelling, what's the first question you're going to ask yourself? Is this fast and itchy, or is it slow and all by itself? Because asking that simple question, well, it could make all the difference in the world.